Hey everyone, we're going to start. Dr. Klein told me this was the keynote session. I am standing between you and sunny skies, so bear with me. There's going to be a lot of levity to this, but a lot of learning, and we're going to discuss things. We made a draft of all the staff, and these are the top 6. You know, March Madness is coming up, so these are the selected ones. We have a Cleveland Clinic team. They've been talking a lot of noise, and then an outside of Cleveland Clinic team and a Cleveland Clinic Florida all together. So 2 teams of 3, okay? And the way I'm going to explain this, I'm going to go through the rules. We're all winners. That's what my mom said when I lost all of my basketball championship games. But remember, there's going to be one winner. And Dr. Klein has offered a 3-day stay here of your choice to the winners. But you have to share the room. You have to share the room. Some of that's true. All right, so let's go to the rules. So first of all, myself and Jared came up with these. We're going to go through the categories and everything, but first the rules, because it's a little different than Jeopardy. As you can tell from the trademark, the strike is through there, so it's not actually Jeopardy. All right, rules. So teams are comprised, this was 2. We made a last-second change. There's 2 teams of 3 staff physicians. There's no buzzer, so there's no point of being aggressive. It is in, you remember when you were an internal medicine resident, a cardiology fellow, you were by nature aggressive. There's no need to be aggressive here. Each team answers the question by writing on a pad. They have a pad here. I will say I'm the final adjudicator, myself and Jared, but we'll defer to Dr. Klein if there's any arguments, okay? So each team writes the answer on the question on the writing pad, and then we'll have an opportunity for discussion. The whole point of this is you all came here to learn. We all came here to learn, so if there's discrepancy, I encourage you to come up to the mic. I'll be saying some things. I've been a staff for 7 months, so my experience is vast. But all of these people here have tons of experience, hundreds of years. Not just kidding. So this is my time to shine. No. Okay. So we're going to keep going through. There's no penalty for wrong answers. If you don't write anything wrong, you'll just be shunned by the group. The score is on the honor code. So we've tried in the past. We've done this with our fellows, and I took the score here, and I got some feedback that my math wasn't great. And I was never good at math growing up. So we're going to do, they keep track of the scoreboards. Dr. Klein thankfully funded those scoreboards, top of the line on Amazon. So they will keep track of the scoreboards. If you see anyone cheating, just let me know. There is no final Jeopardy. At the end of this, we just say it's the end. You get a picture with Dr. Klein, and of course that's prize. And lastly, framed picture. All right. These, this one's, is this cut off? All right, so what this was meant to say is these questions are vetted by a committee. When I've given this to the fellows, the staff in the back are always yelling at me, oh, I don't think that Doppler's aligned. You can't yell at me. It's by a committee. If you yell, you lose whatever amount of points. All right, today's categories. So there's 4 categories total, 4 questions each. So it's different from Jeopardy. And so there's 16 questions to get through in an hour, and I think we can do it. But the first is guidelines, and I thought Dr. Kapadia yesterday had a great line. Guidelines are historical documents, so we're going to call it that. Next is ACHD, or I already hear the moans, and there's a funny story. Jared sent me some, Dr. Klein is a pediatric cardiologist. He sent me his initial slides, and I was like, I don't know what these are. So ACHD, the things we wish we learned in med school. Next is structural echo, which, if you're part of these structural meetings, the heart team meetings, it always ends with, we can try. And then lastly is myocardial. And Dr. Desai has a famous thing when we read our MRIs and you see an HCM patient, you got issues with the tissues. All right, so we have 4 categories. There's no picking categories. We're just going to walk through one by one by one. First, we'll do a test run so that everybody understands the game. So this is the test question. There's no timer that'll be up. I have this timer in my head of what I think the time should be, but it's roughly going to be around 15 to 20 seconds. I'm going to tell you guys when I need an answer or not. So remember, you're not yelling at me the answer, you're just writing it down. Feel free to yell, though, at any time. All right, so test question, and this is worth 100. So the way these questions are is, it's like a 2-step question. You kind of got to know what I'm asking and then know what I'm thinking. So some of these may not be fair. So for the following valvular lesion, what are the 2 most common causes for a 40-year-old from Sao Paulo versus Cleveland? And this is just a test, okay? So I'm going to play this, and I'm showing you this Doppler. And I said it's a valvular lesion. Remember, just a test question. And I can't answer any questions about this because it's not fair. We've seen in the past people have been like, well, what is this like? This is all the data. So I need two answers. One is, what is the most common presentation if a 40-year-old's from Sao Paulo versus from Cleveland?
There is no buzzer here?
There's no buzzer. Remember, there's no aggression. It's only levity. So I give you 20 seconds. You write your answer down. You have markers and paper. So I need number one, number two. What are the most common causes if someone's from... Sorry?
Should we answer the question?
Yes, but you write it down.
No, we did already.
Okay, then you just wait. See, as you can tell, this is... Dr. Rodriguez has been a part of two of these, and this is our interaction every time, so... Okay, we're ready? So we need... What is the most common cause of this valvular lesion in a 40-year-old from Sao Paulo versus Cleveland? So you have to know where Cleveland is.
I think AI is for sure. Valvular lesion.
All right, I'll give about 5 more seconds. 5, 4, 3, 2, okay. All right, team, we'll say this is team one. Team one, do you have your two answers?
You want to mention?
All right, so we have the two answers. So here, and remember there's like honor code here. Don't change your answers.
Should you like this? I mean, how do you know?
I'm trusting you guys. It's a permanent marker.
Come on. You
So
can't
rheumatic heart disease is the first one, and then bicuspid valve, because this is a severe AR. So your answers, team one, rheumatic and bicuspid, and that's in legible English, okay? And then rheumatic and bicuspid. Okay, so this was a test. Do you understand how this works? And if anyone thought this question was bad, you come up to the mic, say your name, and say your gripe. All right, so now we're going to start, okay? So can you guys both flip 100 on your scoreboard? Remember, this is all practice makes perfect, so they understand how to flip. Yes, it's the red. Perfect, thank you.
I thought there was a test.
Or just 100, yeah. There you go, perfect, that's it. All right, 100 versus 100. It's like, how many cardiologists does it take? All right. All right, so now we're starting, okay? So this is guidelines. So all these questions are based on the most recent guidelines in this field. So 2020 valvular guidelines. I will specify American versus European, but we're just going to default to American, okay? So the first, for 100, in what clinical situation is the following test indicated? Remember, not all of these are super hard. This is a learning process. So this is the test, and the question is, in what clinical setting is this test indicated? And I will give you 20 seconds.
Low flow, low gradient areas, or distinguishing between.
I think 20 seconds is going to be too much.
All right, 10 more seconds. Oh, that's perfect. All right, both teams have? Okay, so the clinical test is, this is a non-contrast CT scan. This is you doing calcium score of the aortic valve. And so these are from the 2020 guidelines. So when do we do it? In suspected low flow, low gradient, severe AS with normal or reduced EF. This is when we need to look for something else to help adjudicate. And this is the time when we can use it, especially when they really want it in people with reduced LVEF. But this is the indication based on guidelines. We have cutoffs, sex-specific thresholds, and the physiology behind that is we think maybe women's thresholds are a little lower because they tend to be more on the leaflet fibrosis versus calcification side. Let's see what they wrote.
We wrote distinguishing between true versus severe AS in low flow
I'll take it. I'll take it. Great. Yeah. And then severe AS. Okay, good. So do you write low flow, low gradient? We thought.
No, they did not.
All right, so I'm going to be strict, especially they used to be my staff, but now we're colleagues. All right, so you guys don't get the point. You guys get it. All right, that's 100. Remember, this is by guidelines. And Dr. Klein is, if you're angry.
Alan, go back.
All right, we have.
So the fact that you are showing the groin CT you don't look at aortic valve calcium in the groin unless you do that in Maryland.
Exactly. This is for severe aortic stenosis.
I want to refer to, I think it was Rule 6. The questions were adjudicated by a committee.
Exactly.
But what I'm showing here is this. This is how we do the aortic valve calcium. It's the same way we get an Agatston score based on the calcium. And the couple things, remember, this is learning, is sometimes the calcification extends into the LVOT, and you have to be sure not to include that. So you make your box very small right around the aortic valve. But this is how we actually get the number, okay? All right, so yesterday's debate was really just Dr. Kapadia and Dr. Tong going back and forth over aortic valve. So the question is, in isolated trileaflet aortic valve disease, what are the age and life expectancy cutoffs for patients where SAVR is favored over TAVR, Class 1A recommendation?
These are the
American guidelines. American guidelines. So I need an age cutoff and a life expectancy cutoff where by guidelines, 1A, it's SAVR over TAVR. Regardless of what you heard yesterday, this is by guidelines.
65, less than 65. But I don't know about the life expectancy.
So I need two numbers, age and life expectancy. All right, we're ready? All right, timer's up. All right, team two. We'll start with team two. What is your age and life expectancy cutoff?
65 years old and 20.
Okay, is that what you guys said? 65 and 10. All right, so let's go through it. So by American guidelines, age less than 65, life expectancy greater than 20 years. And Dr. Rodriguez brings up a good point. And what the point of this question is, European guidelines are a touch different. So on the bottom, American flag, I believe this is the EU flag. But the American flag here is 65, and they denote that the life expectancy greater than 20. These are like a little challenging to find out who's going to live that, but there's ways that they suggest that. In these, it's a Class 1A recommendation. So I thought that was pretty telling. Even though we had that debate yesterday, the guidelines really state SAVR is preferred. And then for the European Society, it's SAVR is less than 75, and they use either STS or the Euro score. And I encourage you to go on MD Calc and go through the Euro score. Like a lot of our patients who are less than 65 who have this, they really fit into the SAVR-only group. So it's 1A and 1B, American and European guidelines, but I thought that was helpful. All right? So I believe your team got it, so 200, so just change your score, add 2 more. All right, we're going to move on. So this is the 300 question. I'm going to show you these images, and this is the Doppler. So the image on the left shows the pathology, and it's not particularly the pathology in this patient, it's just showing you the underlying morphology of the valve. And then I showed you a Doppler that is obtained through in case you can't see this, it's obtained through a 5-chamber view. And then the question is coming up, okay? This is a tougher one, which I'm sure I'm going to get yelled at. This patient needs a surgery. This patient does not want to take Coumadin. What are 4 of his 5 surgical options? There are 5 that I thought of. 3 are in the guidelines. We can get creative. But I need 4 of 5 where he doesn't have to take Coumadin.
4 of his 5.
I just need 4 answers.
Okay, I'm missing 1.
And if you give me 6, you get an extra point.
There are 5, which is a 5.
All right. So we'll go team 1 now. What for? So you can speak into the mic if you want.
Ross procedure, homograft, stentless surgical valve, or a stented bioprosthetic AVR surgical valve.
Okay, I think I'll take those. Those are nice because I didn't say how. I like that. Good. Yours?
So bioprosthetic, Ross, homograft, Ozaki.
Excellent. Okay. So so by guidelines, patients with bicuspid aortic valve, severe AR, aortic valve repair can be considered, and we know.
Repair.
Thank you. That's excellent. I'm really proud of you. So aortic valve repair can be considered. Now, a couple other things we could do. The Ozaki procedure, which we'll have a couple slides on what that looks like. I think most of us are reasonably well acquainted with the Ross procedure, which done in good hands has a nice result profile, but at times can have the thought maybe that you're exchanging one valve disease for two. A homograft, which I think kind of fell out of favor for more, it was used a little bit more in the past, but a homograft, and then finally a bioprosthetic valve. And so let's just go through, because maybe some of you haven't seen the Ozaki procedure, which is a bit more specialized. So the Ozaki procedure is basically taking pericardial tissue and making sort of these neocusps. And the idea behind this, if you think about the theory is, in young patients, and we may try to find the ideal patient for the Ozaki is maybe a touch older than a Ross, but you want a little younger than somebody who would normally have a bioprosthetic valve. So maybe the 40, early 50, but maybe 40 range. And the idea here is you're not putting in foreign material to start that chronic immune reaction, and you are improving the hemodynamics because this orifice area is pretty much larger than any prosthesis you can put in. And lastly, in comparison to the Ross, you're not giving double valve disease now, because the Ross, remember, you're exchanging the pulmonary and you're putting in a autograft. So the Ozaki procedure really done, Dr. Ozaki was the one who coined this, and there's a surgeon in our facility who does a lot of these, and we're still trying to find out the long-term data. But it looks rather interesting on echo, and I wanted to share this because remember the point is not to win here, it's just to learn. So you can see that this is a normal Ross. So these are long cusps, like the coaptation line is not where the previous aortic valve annulus is. So if you ever see these, you might think, oh, there's something wrong with the valve, but this is the way it's supposed to look. And we're still trying to figure out how you work this into practice, because our surgeon is a bit hesitant to do these in bicuspid aortic valves where the aortic valve annulus is greater than like 4.2. There's a lot of things we're learning, but it's another possibility. Done in centers of excellence, but it's something that in your patient who's young, who's a little too young for a bioprosthetic valve, doesn't want Coumadin, these are options that you can talk about. Questions, comments?
Yes, the valve that you show initially cannot be repaired, I think.
Correct.
For the audience should be.
So this is why I stipulated that it was the underlying morphology. Thank you. All right. So 400 should be hard. The left image, this patient has a disease. I'm showing you only one clip, and I'm showing you the Valsalva. The right image is the Doppler through that Valsalva. Okay? So take this in, understand everything. And it's a guideline question.
Oh, God.
Okay, this patient is symptomatic despite being on a beta blocker. And we'll say max dose beta blocker. And we'll say he's not on any other meds that should cause anything. What are 3 possible options to help with symptom management? Next options. He better know it. For no reason. So need 3 answers. All right. Okay, so we'll go team 1 first.
Mavacamten, myectomy, surgical myectomy, and alcohol septal ablation.
Okay, correct. And
Same.
same.
Yep.
Okay. So let's just go through. This is a patient who has hypertrophic cardiomyopathy. This is a 3-chamber view showing that during Valsalva you have pretty impressive SAM. And this is a late peaking gradient, and the gradient is 105, okay? So I put 1 disopyramide because it's Dr. Desai's favorite drug, but I'm just kidding. But so these are by guidelines, these are options. Disopyramide, mavacamten, alcohol septal ablation, and myectomy. And let's just dive in a little more for your clinical practice.
Hey, Ben, these are in order?
No, these are not in order. It should have been like ... but it was late last night. So those are not in order. So this is a review that kind of showed a possible framework for how you might think about it. And this is changing because within the last 3 years, and Dr. Desai is responsible for a lot of this data, but mavacamten has shown a lot of reduction in Valsalva gradients, but also in delaying SRT or septal reduction therapy. So one possible way is on beta blockers as the backbone or calcium channel blockers if you're still symptomatic, depending on where you are, depending on the morphology, might consider septal reduction or mavacamten. A lot of this has to be done with age. And really, disopyramide is really coming out of favor. A lot of anticholinergic effects, especially when your patients are on those drugs. So I think that mavacamten is changing this landscape. Dr. Desai, any thoughts on how you work mavacamten into your pathway?
You got to attend the conference tomorrow.
Oh, yes. You have to come on Sunday. There you go. Okay, so
Before church and
before church. See you guys at 7. So this is this patient on mavacamten. So you see this just from the 2D, the reduction in the SAM, because the SAM was significant. And this was the max Valsalva gradient. We went from 105 to 15. This is after about 3 months of mavacamten. And I don't know if it's always that significant. This is from the Valor HCM, and this is Dr. Desai's work. So what I'm showing here is the way they kind of, the participant profile here. So you had the patients who are on mavacamten in the blue. And then at week 16, the placebo crossed over. So you were on placebo, and then you started mavacamten. So this is about a 50% reduction in Valsalva LVOT gradient from 80 to around 40. Now, keep in mind, this patient went from 105 to 15. That's more than 50%. But it just shows that these results are sustained, and I believe there was most recently a longer-term follow-up, and it seems like these results are sustained with very minimal side effects. Any final thoughts?
I just want to make a comment about your example, which shows the wide variety of phenotype for HOCM. This is a patient with severe MAC, probably anterior displaced mitral valve, and a heart that is not that thick. So I think, again, this is one of the multiple spectrum that is shown, but also how effective is this medication in different phenotypes and lower the gradients.
Excellent point. Okay, so I'm going to take a step off. This is now Jared's ACHD. Good luck, everybody.
Can we Google it?
All right, so for the 100-point question, up here we have a parasternal short view, and I also provide the continuous wave Doppler. So can you tell me what the diagnosis?
There's a tricuspid there, and then there's,
That's the VSD.
you think that's a VSD? Okay,
Yeah,
so-
that's the VSD. That's the chart.
Okay, so you think membranous VSD?
Perimembranous restricted VSD.
All right. It's about 20.
Yeah.
All right. Are you guys 1 or 2? What did we?
1, 2.
All right. Team 2. Fine. Sorry. Team 1. What do you got?
Perimembranous VSD.
Perimembranous VSD. And what does Team 2 have? Perimembranous VSD. So,
Both are wrong?
yeah, both are incorrect. So you do get a degree of dropout here, but the flow turbulence is really starting here in the RV. So, and you can see that the Doppler here is almost 4 meters per second. Now, it is very possible this patient did have a VSD repair in the past. What you're looking at is a double-chambered RV. If it was a VSD and it were that big, you probably wouldn't be as restrictive.
This is a $100 question?
Yeah. All right, so briefly, double-chambered RV. So this is characterized by hypertrophied muscle bundles. They separate the RV into a higher pressure, usually apical chamber, and a low-pressure chamber. And it is associated with a perimembranous VSD, but it also might occur in 10% of patients after surgical closure. So it's important for the surgeon to inspect the RVOT for prominent muscle bundles, and these kids, and then into adulthood, still need to continue to be followed. The exact mechanism of why this occurs is still being investigated, but it is an association. All right, the next
And that's
question.
what we meant to say when we said membranous VSD. We meant to say all those associations.
Yep. All right. So,
So do we get 100 points or what?
no, unfortunately, no, not for that one. All right. So, I bet you didn't think I would throw a fetal echo on here. So since it's a fetal echo and the directionality gets all crazy, I provided the right and the left side for this. So tell me what the diagnosis of this fetal echo might be. It can be. In fact, it can be. All right. Team 1, what do you got? Epstein's anomaly. Team 2? Epstein's. You guys are correct. So we see on this fetal echo that here's the mitral valve. Here is where the tricuspid valve should be, but it's apically displaced, which is what you see in Epstein's anomaly. So that is that diagnosis. So Epstein's is caused by failure of delamination of the tricuspid valve. So that leads to atrialization of the right ventricle, which means it's non-functional. So the functional or the actual tricuspid valve annulus is apically displaced. And an interatrial communication is present in most of these patients, and a lot of these patients have severe TR. So Dr. Conj was right. A lot of these patients will develop arrhythmias as a result as their right atrium dilates. And the prognosis really depends on the severity of the apical displacement and the amount of tricuspid regurgitation. Some of these patients will get to adulthood if they just have some mild displacement with, say, mild to moderate TR. But babies who have severe TR from the get-go, the prognosis is not typically as good. All right, so 300 question. So we have some.
This is another fetal?
This one's not a fetal. This one's a subcostal view. So tell me what the diagnosis is. It's regular directionality for this one, with this being right and this being left.
Transposition with the baffle.
All right. All right. Team 1, what you got?
Transposition with baffle.
Transposition with the baffle. And team 2?
Can we have 2 guesses?
Sure, why not? Sure. Let's do it.
All right. So we're thinking transposition, but then struggling to really see. So then we wondered if there was a double outlet going on.
All right. So what we see in this image is we see the 2 outflows right here. Maybe it's seen a little better in the 2D, but we see a connection just above the annuli. So what we're looking at is, an AP window in this case. You're right, it can look like transposition, but in this case, the great arteries are normally aligned. So the AP window is incomplete septation of the great artery, so you end up having a direct side-to-side communication. It can be associated with other pathologies, untreated defects. So if you leave this for out of childhood, you have the risk of developing pulmonary hypertension. So early diagnosis and closure of this is key. I have seen some teenagers where this was missed, and then in that case, then you need to go to the cath lab to determine the degree of pulmonary hypertension. But you have a direct communication here between the outflows.
What's the diagnosis? We are simple-minded people from Ohio. Tell me what the diagnosis is.
AP window.
Can we have points for trying?
Yeah. Sorry. All right. I think you guys will get this. I think you'll get this last one. You only one more. All right. So this, what's the diagnosis, and would you send this patient for cath or surgery? This is a subcostal bicaval view, and this is a 90-degree transesophageal echo.
Sinus venosus is to be
Superior type.
All right. Team 2, what you got?
So we went with the sinus venosus defect.
All right.
We thought it's too big for transcatheter and wrong position, so we went with surgery.
All right. And team 1? Yep, that is an association. And would you send this patient for cath or would you send him for surgery?
Has to be surgical.
All right. So both teams are correct. So it is a sinus venosus defect, and surgery is the correct answer. So in this you have absence of the sinus. In this case, it's a superior sinus venosus defect, and this impacts the connection of the right upper pulmonary vein. So you do have partially anomalous pulmonary veins. So you would send them for surgery, and the surgeon would put in an angled patch so there's no more interatrial communication, and the pulmonary vein drains into the left atrium as it should. And surgery was thought to be the only treatment for this. However, in the adult congenital world, we're looking at whether these can be percutaneously closed. So this is a series of covered stents placed in the cath lab that's able to block the interatrial communication, and you have the pulmonary venous flow actually go from behind the stents into the left atrium. So this can work for adults who may be too high risk for surgery. So yeah, great job, guys.
All right. Thank you, Jared.
We're moving on to another category.
And now I think you guys did very well. Good job. All right, so now we're on structural echo. And remember, we can try. So, what is the main and most common exclusion for using the transcatheter tricuspid valve replacement device, specifically Edwards Evoke, in this patient with symptomatic severe TR? So, the reason for this patient being excluded from getting an Evoke, which also happens to be the main and most common exclusion. Here's the data. And then there's one other slide with imaging. Here is a 4D CT taken in roughly end systole of the tricuspid valve annulus, where the annulus is measuring 7 by 6.2 centimeter. That is not a perimeter-derived diameter. It is just a diameter, but it fits. So what is the exclusion for this patient? And you see all the anatomy. And we'll go 20 seconds. Oh, you guys are ready? Okay, we'll go now. All right, so team two, we'll go, you all first? Annular size, okay. Annular size, okay. This was a little like layup just because of what Jared did to you all. So, 100 points, 100 points. So tricuspid annulus size. Now this is from the TriScend early feasibility study, where greater than 50% were excluded by large annulus size, okay? And we'll go through what this means. So they use a perimeter-derived diameter, so you get the perimeter, and then using our geometry formulas, you can get a maximum. So with the maximum device, and there's a larger device coming, the maximum is 54, roughly, in end systole, and 58 in diastole. So this patient clearly sized out. Now, just a word on this, and Dr. Kapadia gave a talk on this. How do you figure out for your patient whether it's going to be Evoke or a TEER or even a transcaval device? And there's a lot of different ways out there. This is from our institution, several of our imagers and interventionalists, including Dr. Serge Harb, where we talk through about maybe RV function is the crux. And if you have normal RV function and the anatomy is good for TEER or a TriClip, then maybe you go for that if the patient is already determined to need an intervention. You know, this stuff changes because when you have low RV function, if your anatomy is not suitable for TEER, then they say maybe go for TTVR or Evoke. And we know that that sometimes can be a bit challenging. Some of these patients with low RV function, when they get the transcatheter valve, the RV function really plummets. So I think this is another paradigm. All of these to figure out the relationship between your patient having a large annulus, what's the coaptation gap, what's the RV function. All of that needs to be taken into consideration before you figure out which percutaneous treatment is the option. And I'll tell you, I think this is going to change here a lot as we start to realize how people respond to transcatheter tricuspid valve replacement. Okay, question 200. What is the main procedural challenge in this patient undergoing TMVR? Now, this is a valve-in-valve. So the main procedural challenge for this patient. So I'm going to show you another screen of images, but this is a transthoracic 4-chamber. She has a bioprosthetic mitral valve. I'm showing you the gradient, and for those who can't see, it's 32 by 20, max and mean. We know that this patient needs a valve and is going for valve-in-valve, and I'm going to show you another one here. So here's the parasternal long, and then here is from the 4D CT. I'm not showing you any further measurements, but the main procedural risk in this patient who's going for valve-in-valve. And we'll give 20 seconds, but probably less if you guys are ready. So remind you, the patient's already going for valve-in-valve. All right. Team 1, do you want to?
LVOT obstruction?
LVOT obstruction. Team 2?
Yeah, we added to that small neo-LVOT.
That's excellent. I'll take it. So want to express that when you do these, when you do a valve-in-valve, these are stent posts that extend into the LVOT. But really the issue is when you're implanting the valve, you are pinning the prosthetic leaflet from the old valve and kind of making almost like a covered stent. So how do you assess this? So neo-LVOT size, and this is a paper from 2021 on how they walk through in a 4D CT how to assess this. This patient's neo-LVOT was assessed at roughly 9.9, which is very low. We're looking at 17 to 19, 17 to 20 for a cutoff of maybe that this is permissible. But a lot of factors go into this. Patient hemodynamics, conduction, size of the interventricular septum, directionality of the previous prosthetic valve. And then remember, this is all based on simulation. You can simulate as much as you want, but when you're actually in the procedure, if you're canted a little bit, your simulation's off. So we try to do all of this. We try to do our best. And I wanted to talk about a procedure. So you can lacerate the leaflet, the bioprosthetic leaflet. Remember, I told you that the pinning of the leaflet is the problem. So you could lacerate that with electrosurgery, or we developed or kind of coined this, and there's a history behind it, so we'll go through this. So this is called the cleave procedure. Remember, we are in Cleveland, so cleave, clearance of leaflet to eliminate valve excursion. And so here you have, this is the bioprosthetic valve, this is the needle that has perforated the anterior leaflet of the bioprosthetic valve. Remember, surgeon's view here, the aortic valve is on top, so we're perforating the anterior leaflet. So we make a hole through the anterior leaflet, and then next, we balloon that hole. So we are ballooning a hole in the anterior leaflet. All right, so this is ballooning. You see on fluoro, ballooning, and now you see in 3D that hole is now big. Next, we actually implant the valve in that hole because we are obliterating the anterior mitral leaflet, making sure that it's no longer a possible issue for obstruction. Here they're ballooning again, and here you see in transesophageal echo they're ballooning. And then finally, here's your result. You have a nice valve-in-valve here with no significant issues. And on the gradients, I believe the gradient is about 3 or 4 here for the LVOT, and you have a nice mitral valve gradient. But let me tell you the story behind this. So this was done when I was a 9th-year fellow, which is sad to say out loud. But we were doing this. Keep in mind, you see the names there. These are all people that we work with in Cleveland, and Dr. Miyasaka has spoken here, Dr. Kapadia as well. But the way this is set up is there's like 9 doctors in this room, and I'm the fellow, and they're like, what should we call this technique? And I'm not, I'm an average cardiologist, but I'm very good with wordplay. So I was like, we should call it the cleave procedure. And, you cleave something. We're in Cleveland. I didn't make it to the paper. I just got dropped, but acknowledgments are very big. Cleveland does help you in your professional approaches, but this one I did not make it, but I'm actually in the paper. So this is how we started, okay? Cleave procedure. It's a possibility. It's something that's being done now.
It's sort of the unicorn concept, right?
Yes,
Yeah.
It's similar. So the whole thing is like, and there have been lampoon procedures electrosurgery on this. It's all just trying to modify that anterior leaflet to avoid LVOT obstruction. So 300, so you guys both got it.
It was 200 the prior?
200, yep. So 300 question. This patient underwent a procedure where the first attempt was aborted due to this finding. All right, so the patient is already undergoing a procedure, and I'm going to show you the images, and you have to tell me what procedure did he undergo that was aborted, okay? So here's the baseline images. This is a transesophageal echo from roughly a commissural view, and you can tell that there's a mechanical valve. And then here's some color. All right, so I have 2 more slides of images. Here's the 3D view. And if you can, I want to orient you to the en face view here. So we have anterior, posterior. So this is, whatever this is around 11 o'clock. And we have our red plane going through the disc. And so the red plane is here. Okay? And now the procedure starts. And this is the last thing. So we had to abort this attempt because of this. So why did we have to abort the attempt? Or did I ask that? What was the question? Hold on. Oh yeah, what was the procedure? Okay, what was the procedure? And then if you tell me why we had to abort, that's good too. But
We have the answer.
But actually, I'm just looking for the procedure. Okay, and we got about 5 seconds. So what's the procedure we did? Okay, so team 2, what's the procedure?
I think we thought they were trying to do a percutaneous
You're correct. Team 1, what's the procedure? Same thing? Okay, and so what's actually happening here? Does anyone know why we had to abort here?
One of the discs in the bileaflet valve got stuck.
Excellent. And so the whole point of this is to show, so we orient in these structural procedures for paravalvular leak. You want to get as small a box, and I see several of you who are in the Thursday workshop. Remember, you don't have to get the whole mitral valve. You want as much resolution as possible. So we've narrowed in on roughly around 10 o'clock, which is where we knew the leak was. And you see the device coming in. And the important thing is that with your multiplanar reconstruction, we have the green plane going through the disc, so almost orthogonal to the disc. And you see here that nothing is opening. And I want to contrast that to the previous, where the red plane is actually going through, and you see both discs are widely opening. So this is a known risk of doing PVL closures on mechanical mitral valves, and it's a nice way of showing this concept. So the answer was PVL closure. Good, everyone got it right. All right, now this is the 400. This is rather challenging. This one will take a little bit longer. So the following patient has radiation heart disease, has had a prior cardiac surgery, had 1 prior transcatheter procedure. She now underwent percutaneous procedure for her mitral valve. I'm going to show you the fluoro, and I'm going to show you the echo, and then you have to name the 6 devices that this patient now has on the fluoro. This was pre-intervention. Radiation heart disease, has already had 1 open heart surgery, as evidenced by the sternal wires on the left. This is a, I think it's technically a little LAO. It's a little caudal, yeah. So I need 6 devices. I believe there's a total of 8.
This is a bioprosthetic mitral.
She had an ASD closure, and she's got a mechanical aortic valve.
Yeah. Yes. Mechanical aortic valve.
All right, we'll give another, since there's 6 questions, we'll make up a number. We'll give another 10 seconds. Does the audience know? 6? Yeah, we feel comfortable with 6.
Oh, gosh.
Okay, now we're gonna go. Do you guys have? There's literally a fire happening, so we have to go. You got 6? All right, 10 more seconds, then I'll take what you have. I need 6 devices.
An implanter.
And then there's a leadless pacemaker.
Okay, I'll take it. So team 2, how many devices do you have?
Leadless.
Okay, team 1, how many devices do you have?
Leadless pacemaker.
You got 6?
We've got 6.
Okay, does anyone know, anyone from the audience want to name 6? You can come up to the mic. Dr. Cohen, I think you'd probably know because you do these, but Johnny knows. Anyone? Okay.
There's 2 cardioform devices.
Okay, 1 and 2.
There's an aortic mechanical valve.
Okay, that's 4.
There's a sapien valve.
Okay, that's 5.
And then there's a little plug,
Okay,
like a vascular plug. How many have a patient?
that's 6. There's 7 devices total here, and there's a mitral clip here. It's in Mac. So there's 7 total. Okay, so let's see what you guys got. You could just read it through.
So we've got tricuspid ring, the bioprosthetic,
mitral,
the mitral position,
mechanical
mechanical aortic
aortic
valve.
valve.
We thought with the root reconstruction as part of the, like a...
Okay, but I'll take that as one.
We counted that. The ASD closure with an implanter and a leadless pacemaker.
Okay, but what you're looking at as a leadless pacemaker is a mitral clip.
Got
But
it.
that's good.
Yeah.
That's 4. That's good. What did you guys get?
So we had mechanical AVR, tricuspid valve ring, transcatheter mitral valve. We had a mitral clip. We had a leadless pacemaker, and then we had a plug.
Okay, good. So both did very well. 4 each, but okay, so let's go through. I'll show you. I'll show you. Okay, so let's talk, because this is kind of just a unique thing. Number 1, tricuspid valve repair. This is an incomplete ring. Number 2, mechanical aortic valve. Number 3, that's cardioform ASD. Number 4, cardioform ASD. Number 5, mitral clip. Number 6, valve and MAC. Number 7, this was just another radiation heart disease hallmark, but you see the aorta is lighting up. This is porcelain aorta. And number 8 is that AVP4 device. So what happened to this patient? Okay, so AVP4, that's the vascular plug. See that dot? There's another dot behind it. I didn't show the orthogonal, probably could have. That's why I only wanted 6. So let's talk. So this patient had a valve and MAC, and previously precluded in 2021 was evaluated for valve and MAC, and the annulus was too big. So this is from the group in Seattle. They published this technique. It's an early technique called ARCTIC. So annular reduction by cinching with tear in the commissure, TMVR. So what they do, the commissure is too big, or the annulus is too big, valve and MAC, and so they put a mitral clip in the commissure, and they shorten the annulus so that now you can put a valve in the MAC. So this is what we did for this patient. So to show you again, the first one was you put the clip first, make it smaller, then put this. So how this patient ended up. This is radiation heart disease. First surgery was aortic valve, mechanical aortic valve tricuspid repair. Then shortly thereafter, PFO closure. That was the first one. ASD closure, technically. Then she develops severe MS. And so this procedure that she recently underwent was valve and MAC. So they cross the septum. They first put the mitral clip to shorten the annulus. Then they put valve and MAC. And then on their way out, they have to close the septum that they just opened. And before that, they had a PVL, and they closed that with an AVP4. Okay? All right, you don't have to know that for clinical practice. Because there was previously one device, and then went through the septum again, and then it was a huge left to right, but RVSP was 100, so I had to close.
This is why when you have radiation heart disease patients, it is best to do a complete operation the first time around. Otherwise, you're basically creating makeshift tents here.
Right. And the hard part in this patient, mechanical aortic valve is around, I believe, 19 years old, so didn't have that disease back then.
Can I give a plug for our session on radiation heart disease tomorrow morning? for
That's why
those
it's
of you
here.
Who would like to learn more?
Yes. Okay, good. So we have 4 more questions. Nobody got any points. We went for 6. All right, so myocardial. We have 4 questions left. Bear with me. They won't be that hard. All right, issues with the tissues. So what explains the two demarcated signs on CW Doppler through this patient's ventricle? So this is the echo. So this patient has something. And next, is everyone good? I'm going to go. This is CW in that pathway, and I've starred what I want you to explain. So 20 seconds. You have to explain the first one. I'll take names. I'll take whatever, anything that resembles what could happen. I believe another plug, this is in Dr. Klein's book, which he's giving for half off today, so it's also maybe not true. All right, so we'll take 5 seconds. So I need 2 answers. All right, so team 1, let's go with the first star. What is the?
Lobster claw appearance.
Okay, lobster claw, and then what's the second one?
This IVR flow.
Perfect. Okay, team 2.
So mid-cavitary obstruction and
Yep.
lobster claw abnormality.
And what's this one?
Diastolic filling from the apex.
Okay.
Apex, yeah.
All right, so what's actually happening? So this is lobster claw, and this is diastolic paradoxical jet flow, and let's show what's actually happening. So lobster claw, this is has been described before, but you have this mid-systolic drop in LV ejection velocities due to obstruction. Now the obstruction can be at different places, and PW Doppler really helps with this. Can be seen often, even with, you have abnormal papillary muscles, you have mid-cavitary obstruction. Now, diastolic paradoxical jet flow, the interesting part of this is, should you see this? And what I'm specifically pointing to is here. Systole is over here, and then you still have forward flow in diastole, and I'm going to show you the color image. The real question is, if you see this with an apical aneurysm, you know it's from that. But if you see it without an apical aneurysm, then perhaps in clinical practice, the tool here is you have to search for it, because sometimes the apical aneurysms are in the inferior apex. So to show this a little clearer, this is a DEFINITY image, a nice clear diagnosis, and then this is that diastolic flow you see. So this is actually obvious, you see it nicely, but in clinical practice, should you see that diastolic flow, I believe that's when you have to really look closer.
So
Any thoughts?
bottom line is generally it is our expectation if you have apical HCM, you need to give contrast because don't rely on these Doppler signs. You got to make sure there's no apical aneurysm because that's a risk factor for primary prevention ICD, and you could have thrombus within. So,
Excellent.
Make sure the image is not foreshortened.
yeah, and of course, the quality of the images, you cannot have a foreshortened apex.
Right. Okay, excellent. So both teams got points. All right, what next imaging study should be performed for confirmatory diagnosis in this patient who has atrial fibrillation? And it's, remember, imaging study for confirmatory diagnosis. This is the echo. Has atrial fibrillation. And then I'm going to show you another one. And here's the tissue Dopplers. So remember, the imaging study for confirmatory diagnosis.
But this is an echo question or a general question?
Part of the rules I cannot answer, but this is there's echoes. But what imaging study for confirmatory diagnosis? Yeah. See, I'm trying my best to be not a Russian judge. All right. Right? Okay, team 1, PYP, team 2? PYP. Okay, so this is amyloid, right? And this is a nice, we do PYPs with CT for aligning the planes because what you'll remember is if you just do this with tomography, rotating X-ray images, sometimes blood pool can show up. And so when you superimpose this on a CT, you can see that this uptake in the myocardium is clearly in the myocardium and not in the ventricle itself. It's not blood pool. So this is amyloid, and this was a nice review, and Drs. Desai and Klein were on this one. But it just shows some of the particular hallmarks that maybe you should think about further diagnosis. So an EA profile such as this is a very restrictive profile, but also that the A wave is very small. The other thing I want to kind of highlight is this 555 sign. So, a very specific sign. Now, when tissue Dopplers are very low, lateral E, septal E, and your S prime, when things are very low, less than 5, that's when you should really consider looking for amyloid. Okay? And we'll have, this is about last one. So, most likely underlying diagnosis with the following imaging findings in a 35-year-old patient with VT. So this is a 35-year-old patient with ventricular tachycardia with these imaging findings. So 4-chamber on the left, RV on the right. 45-year-old patient with VT, these imaging findings. I have one more imaging study after this. And this is the CT. Now, for those who don't read CT, I'm showing this in a coronal projection. And what I want to highlight is a rather normal lung here, and kind of in this almost perihilar distribution, you have these things. None of us are radiologists. Some do read CT. But these are the findings. 35-year-old with VT with these. And we'll take 10 more seconds. Okay, team 2. Can I have your answer? Cardiac sarcoid. All right, team 1. Cardiac sarcoid. Okay, good. So what I want to show is this. This almost like lymphonodular pattern in the perihilar region. This is like a very nice typical pattern for lung sarcoid. Now, when I say typical for lung sarcoid, that's probably an oxymoron. They can do a lot of different things. But this pattern specifically with the young patient presentation and the RV findings is typical. Now, this patient had a cardiac MR, and I think there's a few of us here who read MR, but what I want to show you first, these are the LGE sequences. And it's very hard to find LGE in the RV because it's so thin, but this sort of white line is a bit concerning. And here you see it even better in the short axis view. So he has LGE in the RV, and the RV is large. So what's your differential there for a young patient? Really, we think about 3 main things. It could be myocarditis, could be ARVC, or it could be sarcoidosis. There are other rarer causes. You have to make sure that there's no shunt causing RV enlargement. But really, when you have that delayed enhancement there, these are your 3 things. And myocarditis typically causes a slightly different pattern. It's rare to have isolated RV. And ARVC, you normally have this aneurysmal or dyskinetic segments as opposed to just a uniformly down ventricle. But this is the diagnostic challenge. Okay, so all of you got it? And we have time for the last one. All right, what is the cause? This is the last question. What is the cause of this patient's outflow tract obstruction? And I want to really clue in. I'm showing you these images for a reason. This is a 4-chamber, and this is a short axis of the aortic valve. And I'm going to ask you, what is the cause of this patient's outflow tract obstruction? All right, I'm going to show you the Doppler, okay? Everyone looked at this? These are the Dopplers. CW Doppler in a roughly 3-chamber-ish going through the aortic valve. You'll have to believe me that this is going through the aortic valve. And then with Valsalva through the aortic valve. So you have to know the profile, and I showed you the images. So what is the cause? Can you go back to the... Yes. Okay, team 2, you guys have ready? You can take it. I didn't give you enough time, but.
And the next view?
The next Doppler. Okay, so due to time, and we need to figure out who's going to get the free nights. So team 1, what do you get? Subaortic membrane. Team 2? Subaortic membrane. Okay, good. So the most important thing is this is the underlying pathology is hypertrophic cardiomyopathy. This patient has an apical or mid-ventricular variant. 1% association with HCM is subaortic membrane. And I'll show you this. See a little clearer here. And you see nicely the color flow. And this patient particularly had an MRI. And I think MRI sometimes shows this nicely in our LVOT stack. The aortic valve is here, and what you're seeing on MRI, that black flow is analogous to aliasing in echo. So you have a nice, clear, discrete membrane. You know, we tend to see these membranes very rarely, but they have been associated with HCM in about 1%, and they're like usually these tunneled structures. So this was what was extracted out of this patient. And here you have nice sort of finding of the subaortic membrane flow, which is the red, and then the late peaking dagger, which can be seen in concomitant cases. The important thing that I showed, and I think both teams clued on this, is if the aortic valve opens nicely and you have a typical pattern here, which is not late peaking and is not MR, it does not start right after the QRS, then you have to suspect subaortic membrane. All right, so those are all the things. I want to thank Dr. Klein for giving myself and Jared the opportunity